the tourniquet off, blood flow is restored. That's angina or ischemia. Leave that tourniquet on long enough, tissue's going to go. That's a heart attack. That's infarction. So infarction means tissue death. Ischemia means lack of blood flow. And that doesn't matter what we're talking about. When we're talking about brains, bowels, ischemia is death.
So are there almost always ignored warning signs with a heart attack when someone finally has a heart attack? It sounds like it takes a while for you to get to the point where you have dead tissue, unless, again, like you said, you have the little.
You know what, I'm going to tell you that I think it really depends on the patient. If you have people who have a lot of aches and pains and things, they tend to minimize. And like I said to you, my diabetics don't get clear-cut symptoms that they could attribute to other things. My young, healthy people usually are fine and get like an elephant is sitting on my chest. They have clear-cut symptoms. That, do they ignore them sometimes? Oh yeah, they wait till they have massive heart attacks before they come in because they're in denial. But their symptoms are often very clear. Some people's symptoms aren't that clear-cut. So, like I said to you, some women's, because of lack of knowledge about cardiac pain, people often attribute it to other things. That's the big problem. What'll happen is, when they feel badly enough, that's when they show up, if they don't have good knowledge about cardiac disease. And some people don't get any symptoms at all because their heart attack is secondary to another disease process. They come in with a whopping UTI. They come in with a whopping pneumonia. They come in septic from some kind of infection. Their heart attack is not driven by a primary cardiac event. Their heart attack is driven because of the strain of the illness. And we know, because we draw enzymes on them, that they've had a small heart attack. It's not going to cause muscle damage, but the heart's been strained, and we can tell that by the troponins being low. Now, if you had somebody that came in really sick and never had any heart disease before, and they have a non-ST elevation MI secondary demand, when they get better, they're going to get a stress test. Because chances are they have some underlying disease that hasn't raised its ugly head yet, and the severe illness gave us a clue that there was something else going on. That make sense?
Mm-hmm.
So, an MI, sudden and extended obstruction of blood flow. That tourniquet stays on long enough, tissue's going to die. Subendocardial infarction means under the endocardium, so it's not. Transhumeral means it goes through the whole muscle wall. Endocardium means it only goes through part of the muscle wall. So a transmural MI means that the whole muscle wall has been damaged. And when you do an echo, you're going to have what we call akinesis, or no muscle motion in that area. We talked about a non-ST elevation MI means that you don't have any EKG changes, but you have an elevation in the troponin. ST elevation, the elevated troponin with EKG changes, and when we do that echo, because of the EKG changes, you will often see either hypo, meaning less than normal wall motion, or akinesis, lack of wall motion, depending on how bad the heart attack is. The good news is we see less akinesis and more hypokinesis because people are getting treated quicker. So when you have tissue death, what is it? It dies, right? Your muscle, it dies. So if you have ischemia that lasts more than 15 or 20 minutes to a particular area, you're going to end up with tissue death. And how much blood flow to how big an area and how deep that area goes is what determines how big the MI is. So you can have little heart attacks and big heart attacks. You can't tell by the troponins. You have to tell by the echo. The other interesting thing is when you have a heart attack, you can have what we call stunned myocardium, which means that the muscle is stunned from the damage. So when you do the echo immediately after a heart attack, you're going to have them do an echo 2 to 3 months later. And what may have been hypokinetic or akinetic, you may get better wall motion because the heart muscle, some of it was stunned, so that their ejection fraction might be better after that. And you might have better wall motion in the area that was injured. All right. There's a thing called Takasubos. Talk about a mind-body connection. Takasubos is when you have a very, very strong emotional event, the death of a spouse, the death of a child, whatever. And you literally, they come in and they are having a heart attack. They have chest pain, they have a broken heart. Yep. It's called Takotsubo's. And so what happens is they literally have a decreased ejection fraction. They often have normal coroners. And so what happens is a tincture time. Several months down the road, they usually get their raw motion back. But talk about the mind-body connection. We talked about stress earlier, about what affects, all right, so that truly indicates how much our emotions and our stress level and our catecholamines and everything do and affect the rest of our body, you know, as a big effect. So we talked about it. Where can it be? Everywhere. I also ask them, do you have any associated symptoms? So when somebody comes in, they tell me, do you have chest pain? No, I have chest pressure. Okay, where's the pressure? It's right here. Does it radiate anywhere? Does it go into your shoulder, into your arm, up into your neck, into your back? Do you get sweaty? Are you getting nauseous? Are you dizzy? You know, do you feel really anxious? Do you feel your heart palpitating? All of those things I ask them because those are associated symptoms. Okay, so it's kind of important to know what, to help them also to identify that those are symptoms that they need to know about. The tropes we talk about, that's what we use the most. We don't use CPKs anymore. When somebody has rhabdomyolysis, when they lay on their side because they can't get up for all night long, when they fall, you know, and the old guy falls, and, you know, the nurse's aide comes in the morning and finds him on the floor and he's been there all night long, we check a CPK and a trope. The trope's going to be elevated, but the CPK is going to be through the roof because he's had muscle damage because he's been lying on his side. So it's all those, that breakdown, all those muscle fibers. You're going to flush them with fluids to get rid of all those dead cells. You're going to get a lot of fluid. We're going to look at the liver because we worry about liver congestion. That's what we worry about with rhabdomyolysis, but it's a different kind of, you know, that NB is up because it's muscle damage. You know, I can't even remember using a myoglobin, and LDHs were used back in the beginning of the 80s when we didn't have troponins. We don't even see them in the body. Well, this just shows you some lovely cell necrosis. Liquefatic. Remember we talked about that liquefatic necrosis here, where the tissue actually becomes liquefied because the tissue dies. So it breaks down and becomes liquefied. We talked about treatment for a heart attack. Sometimes it's just medicine. If the vessels are too narrowed and the damage, if the blockages are too diffuse and there's no area that you can bypass, or if it's just one vessel, rarely do they bypass one vessel. They'll treat the medically. Beta blockers, ACE inhibitor, aspirin, decrease the workload, increase the strength of the contraction of the heart, diet and behavior modification, cardiac rehab. Thrombolytic therapy, TPA, well, we can get people to cath so quick that we rarely TPA anybody. We TPA brains, but you know, nowadays, if you get somebody in quick enough at onset, you're going to send them right to the cath lab. We don't use TPA for hearts that much anymore. But I remember when we did, because I was involved in the Gusto trials where we were doing, you know, we were using TPA when we had the blind study to see if it worked. I'm actually back from when we used streptokinase, which people bled out all the time from that. We don't use that anymore. But the TPA was kind of the second generation with less problems with bleeding, and it would literally break down the clot. But because we can get them to cath so quick now, if people get in soon enough, we can get them to cath just as quick as we can TPA. So the reason people have a greater risk of having a heart attack within a week to 10 days afterwards is because the heart muscle that's affected because of tissue death is soft, and the chances that you have rupture there is greater, which can cause further endothelial damage and another heart attack. By week 3, remember we talked about muscle changes that happen with this. This fibrin goes in, it causes scar formation, and so everything becomes firmer, and there's less chance of rupture. But eventually, that scar tissue, when you have scar tissue, it's not vascular anymore, and it's there, but it's not moving. So that scar tissue has to do with that akinesis. with any infarction, you have cell death. We talked about myocardial stunning. When parts of the heart that actually aren't damaged are stunned because of the heart attack, so the heart attack might be here, but the surrounding tissues may be stunned from that lack of blood flow there. And that muscle is considered hibernating myocardium. It's kind of hiding, waiting to work again. And actually with Takasubos, you essentially have hibernating myocardium. All of a sudden you have a reduced ejection fraction, no underlying ischemic disease, and it reverses back to working normally after time. So, I mean, we talked in the beginning that when we look at drugs, they always consider a 150-pound male. Well, guess what? Not everybody's a man. Not everybody's 150 pounds. So with women, less is more. Always start. And with elderly, less is more. When it comes to heart failure, so when we talk about heart failure, we're talking about either diastolic or systolic heart failure. Either their heart's not relaxing enough or their heart's not squeezing enough. Theirs is often due to vasospasm, so it's not ischemic. In other words, those people will have chest pain and they have lack of blood flow, and they might even have a heart attack from the spasm because it's been lack of blood flow long enough to cause a heart attack. But we go in and look at their vessels and they often don't have blockages. So it's more, women can be more difficult to treat. And I already said that we use calcium channel blockers with those women because it decreases their spasm. Whenever you mess with the heart muscle, the chances that you're going to have irregularities in rhythm are going to happen. More VT, more VF. When I first started treating heart attacks years ago, everybody was on lidocaine. And lidocaine has come in and out of vogue. If you've ever done ACLS, Advanced Life Support, you know, lidocaine was one of the first drugs. Then you wouldn't hear about lidocaine was off. For a while there was Pronestil, then there wasn't Pronestil. They go back and forth as to what drugs you use. Lidocaine is used much less than it used to be. We look very carefully at potassium and magnesiums now. Magnesium wasn't big. We now know that potassium and magnesium levels have a lot to do with arrhythmias. We want their Ks up above 4 if they've got any heart disease, and their magnesium should be 2 or greater. So I think that we use less lido and have less arrhythmias because we have better understanding of how important that electrolyte balance is. The other thing is too, is when you have heart damage, you can end up in heart failure. You have less of the pump working. So people can go into acute heart failure because it's a supply and demand problem. And they can go into cardiogenic shock. You have enough heart muscle damage, you're going to have decreased cardiac output, you're going to become hypotensive. Cardiogenic shock means not only is the heart not doing well, but perfusion to the kidneys becomes worse, and you end up with kidney failure. So it's multi-system cardiogenic shock. So the other name for pericarditis, just inflammation of the heart muscle, is Dressler syndrome. You don't hear it that much. But Dressler's is when you develop pericarditis after a heart attack. So if you think about it, if your heart damaged, you often end up with inflammation of the heart muscle, and that causes pericarditis. And you usually treat pericarditis with non-steroidal anti-inflammatories because it's an inflammatory process. Rupture is a real small percent, 1 to 3%. And you know, when I remember when we were in these TIMI trials and Gusto trials for all these drugs, they would always say time is muscle. You want time to the cath lab, you want them in, you want them treated. You know, if somebody comes into the ER, you don't screw around. Throw some O2 on, throw some lines in, get rid of their chest pain. Give them low pressure if you have to decrease their heart rate, you know, and load them with an aspirin, a full aspirin. So you're really trying to decrease the workload and increase blood flow to the heart. You have to put them on paste. So beta blocker paste, oxygen, and to decrease the workload. So we talked about heart failure. When that left ventricle isn't working well, if it's not relaxing enough, it's diastolic heart failure. If it's not able to squeeze as much as it should, it's systolic heart failure. So And then we even complicate it more. You have left-sided heart failure and right-sided heart failure. So left-sided heart failure is when fluid is backing up in the periphery. So remember, the left ventricle is pushing blood out to the aorta to the rest of the body to be oxygenated. So if you have liver congestion, if you have high pressures on the right side of the heart, okay? No, if you have pressures high on the left side of the heart, what's going to happen is you're going to have a backup of pressure in the pulmonary arteries, and you're going to have, you're going to end up with RALs. So when somebody's in left-sided heart failure, you're going to hear RALs. They're the people that say, geez, I started having to put my pillows up, I'm getting this RAL in my chest. That's left-sided heart failure. Right-sided heart failure is when they have lower extremity edema, and they'll end up with JVD. Because it's the right side of the heart that's getting congested. So there's a backup of pressure against the ventricle to push them. And so their LFTs will often be elevated because they have liver congestion, or because they have all this edema. They might have some ascites, but they're going to have low extremity edema. It doesn't matter which one is, patients become symptomatic. Sometimes right-sided heart failure, if it gets bad enough, goes into left-sided heart failure. If people don't pay attention to those weights that I tell them, 3 pounds in 3 days, 5 pounds in a week, I want them on the horn. They're not weighing themselves. Okay, and they come in and their ankles look like elephants. You see, what brings them in is the shortness of breath, not the elephants. They come in. I said, well, your ankles haven't been like that. Like, that didn't happen in 2 days. It's like, well, no, and then you kind of, you've been taking meds, yeah? Weighing yourself? Yeah, I weigh myself you need to every day and write it down. How's your diet been? Oh, it's been great. Yeah, let's talk about that. Oh, I forgot about the clam chowder that somebody brought over, or, so-and-so brought, well, I'm getting these home-cooked meals from Windfall Market. Nice home-cooked meals. I said, they're loaded with salt. That's why they taste so good. There's tons of salt in them. You can't eat that stuff, you know what I mean? Or somebody made me soup. Yeah, they're using canned stock to make the soup. You know, it's the hidden salt that get people in trouble. And I really try and explain this to people, because my people that come back in heart failure over and over again, it's usually because of dietary restriction. And they're not weighing themselves and waiting too long. So the important thing about heart failure to know is that every time a patient gets admitted with acute heart failure, they've chipped off a little more of their functionality. Every admission, you're chipping off a little more of their functionality. And I'm very clear with patients about that, because they don't get that. Doctors don't sit there and explain this crap to them. They just don't. They don't take the time. My feeling is I have a responsibility to try and keep this patient out of the hospital. Say, listen, what do you like to do? Oh, I want to go to the beach with my grandkids this summer. I'm going to do this. And I said, well, every time you come in with heart failure, when I send you out, you have a little less function. And chances are you're not going to get it back. So we need to figure out, as a team, how we're going to keep you out of the hospital. This is what you have to do. This is what I have to do. And I really try to incorporate the team approach. I get the VNA in there, telemonitoring with weights. We now have a heart failure program at the hospital. If people are readmitted, there's a nurse who calls them and tries to reinforce about different things. We'll send out a case manager, a social worker. We'll get the pharmacist to go out there and make sure that their meds are done. Oftentimes the patients really can't be doing all that stuff with the meds. God forbid if they're on meals and meals, they might as well just be sucking on a salt shaker. Really Have you ever seen them? I would not feed those things to a dog.
It's terrible.
They are the worst meals. Have you ever seen them? They're worse than the TV dinners that came out in the 50s when they first started. They're disgusting.
It's worse than MREs.
They are awful. I mean, I had this little old Chatham fisherman that I adopted, and he was as skinny as a rail. He never cooked. So we tried, and I was there once, and I looked at her and I said, "You're not eating this." I threw it away. I said, "I wouldn't pay $2 for that." It was horrible, horrible. This hard lump of potato, these peas that looked like they'd been over. Oh, it was just disgusting. I just couldn't. God bless them. No wonder they're not eating. You know, and it's hard when people get older. They lose their taste buds. They don't want to cook. They often have trouble getting out and getting fresh fruits and vegetables. It's really difficult. So I try to ask them to keep it simple. Cottage cheese, you know, buy the the $1 cluck, you know, the $5 cluck, and eat the chicken for the week. Do you know what I mean? Try and keep it simple. And chances are they'll stay out of trouble more that way. But the biggest problem is food. That's why they usually end up having failure. And of course, like I said, they keep chipping off a little more and a little more of their heart from time to time. That's why it's considered a fatal disease. You know, most people with heart failure don't live that long when they have systolic heart failure. The max is usually about 10 years. So it's a progressive disease. And so we play a very, very vital role in trying to educate those people and keep them out of the hospital so that they could follow the light too. Right, so cardiogenic shock is when that left ventricle just doesn't work well, you're not having enough perfusion to the heart, you have increased pulmonary congestion, so that they're tachypnic, they end up with rouse, they end up hypotensive. When they're hypotensive, they become acidotic. When they become acidotic, they're not breathing as often because they're breathing more because they're acidotic, and then they end up hypoxic. Kidneys end up working, they're just a mess. They end up a mess. If you don't treat those people and keep an eye on them with a big MI, they're gonna die. So your young MIs that come in that are very symptomatic with a real coronary problem, if you don't get them and get on right away, that's why they often be fatal. So you have to be really careful. And I see less and less cardiogenic shock. I used to see it a lot when I first started practicing 35 years ago. We saw a lot more of it. We're much more aware of what to look for. We treat it much more quickly. We know better means of treating things so that they don't progress. And so I don't think that we see as much of it. And we certainly don't see as many fatalities. These are just some other studies that you can look at. They talk about that heart mortality is greater with people that don't drink coffee at all. Of course, they don't talk about whether it's decaf or caffeinated either, because my atrial fib patients, I tell them to stay away from caffeine. So I don't know if it's the coffee itself or whether it's the caffeine, which is interesting. So, and there's just some other articles we want to look about. They talk about chocolate consumption. And of course, my problems with the patients are that they think always more is better, and they think that eating a whole bag of those chocolates is fine, and that's moderation is different. So when you start getting a widening of the pulse pressure, that means that you have a greater chance of underlying cardiac disease. So when your systolic and diastolic blood pressure, when you get that widening pressure, that's always a cue for me to worry about if they have anything underlying that. And so in our older patients, we want to pay attention to that. We want to pay attention to that widening pulse pressure. People don't think about that. They just don't. But that widening pulse pressure is often a cue that they've got some underlying heart disease and may get them into trouble somewhere down the road. So it's good to pay attention to that. Itis of the endocardium, inflammation. It can be acute, sudden onset, subacute. If you have a strep infection, you'll often end up with some endocarditis. IV drug abuse, very common. Unfortunately, I see it a lot. These kids come in with big abscesses, horrible endocarditis, and their valves are just getting chewed up. It's very sad, very, very sad. It's difficult because often these kids just don't get it. Then you run into the dilemma, do you replace the valve that somebody's still using? So it's pretty tough, but it has to do with bacteria. The other place you can get endocarditis is bad dental disease. So people that don't take care of their teeth often end up with a bacterial infection that goes to their heart from their gums, and they end up with endocarditis. You can develop these little osmonoles or splinter hemorrhages, or these little flame marks on your fingers. They're called splinter hemorrhages. And if somebody's subacute for a long time, they'll end up with a splenomegaly. The spleen will actually get enlarged. And what happens with that is there is bacteria that actually attaches to the valves. And when you do an echo, if sometimes you can't see it on an echocardiogram. You have to do a transesophageal echocardiogram, which means that you stick a probe down the esophagus, and there is nothing in between the esophagus and the heart muscle, so you get really good images. You know, if I do a transthoracic, I have this bone and muscle I have to go through, so sometimes you can't really get a good look at the valves, but it looks like kelp. It's the only way I can describe it. Have you ever seen kelp seaweed? You know, that kind of big green seaweed? When you look at the vessel, it looks like there's kelp floating off the valve. You can see it. So it looks like an appendage is actually floating off the valve. And what will happen with that is it will actually cause scarring so that the valve becomes ineffective and can lead to needing a valve repair or replacement. So it's not good. We talked about, well, raw spots are retinal hemorrhages. I usually refer to the Osborne nodes on the calf of the finger and the toes with these raised red areas. They often, like I said, you end up with that, those splinter hemorrhages in your nails. And then nail clubbing with long-term subbacterial endocarditis. They'll actually get clubbing. So the two things you see clubbing with are with that and with long-term COPD. And it's because of oxygenation. So what kind of valve disease do we have? Well, we have, the valves either become stenosed or narrowed. So when you look at usually from calcification, calcific deposits occur around the annulus, which is the outside rim of the valve, and it can cause it to get thickened and narrow down. And regurgitation is when the valve can't close all the way, or it shunts both ways. You get regurgitation. So instead of it closing like a door like that, it's like a cafe door. And because it doesn't close effectively, you get shunting of blood back to the chamber that the blood just come from. When you have strep as a kid, you often can end up with mitral regurg. Women are more prone to have mitral valve prolapse between the ages of 25 and 45. Aortic stenosis is just narrowing the aortic valve. Rheumatic fever. People that have rheumatic fever often end up with aortic stenosis, so we always ask for that history. And if you think about it, with severe aortic stenosis, that aorta, if it's small and narrow, that poor ventricle is trying to push out oxygenated blood, and if it can't, you're getting less blood cardiac output-wise, right? So you have a patient who turns around, they get up, and of course we have all those different vessels that constrict to push the blood up, but you've got a narrow, real narrow vessel. What happens is not enough blood's getting to the brain, people syncopate.
I had grayouts a couple times a year since I was a kid.
Probably not due to that though. It could be because you're vasovagal. It's probably to do with your autoregulatory system. Number one, when you're a kid, there's a lot of things that go into that. I guarantee it's vagal. So it's either because you were dehydrated, it can be from dehydration, it can be that you moved too fast and your blood just couldn't get up to your brain quick enough, because it usually happens with movement. Sometimes when people are really sick, because everything's going quicker, you can end up with grayouts, but it's usually to do with you're not perfusing to the brain, but I guarantee it's not from aortic stenosis, especially if it's not when you were a kid. Is it usually when you go to get up quick?
Yeah, usually in the mornings.
Yeah. So if you think about what happens is your body's at rest,
Yeah.
and all of a sudden, of course, we jump out of bed and we want to start going right away, and the blood's your body hasn't realized it's out of bed yet. So with my older people that I put on beta blockers, I will always tell them, I want you to change position more slowly. Get up and sit on the edge of the bed first, because you need to let your body know that it's getting out of bed. Give it a little warning. So you probably just need a couple of minutes to sit on the edge of the bed before you do that. But I guarantee you it's just because of the vasoregulatory system. The blood's not getting up to your brain quick enough in the position. So move a little slower. Yeah, sometimes with aortic stenosis you'll hear a split heart sound, S2. And I put this in here because a lot of people never get to hear murmurs or listen to that, and I think it's really important to understand what they sound like. And this is a great little place where you can actually listen to the heart sounds. So, you know, to me, a picture or a sound is worth a million, or I can explain it till the cows come home, but when you hear it and you see it, it sticks in your head. So you can have the same thing with the mitral valve. The mitral valve can stenose down too. Pneumatic fever, again, can be part of the problem. But the symptoms are different, because if you think about it, where's the blood going from the mitral valve? Going up to the pulmonary artery, right? So you're going to get short of breath, right? Well, actually, the mitral valve is between the upper chambers and lower chambers, but you're going to get short of breath because of lack of blood flow, because of the pulmonary artery. You're going to get fatigued again because it's a lack of blood flow. It's a supply and demand problem. Sometimes with mitral stenosis, people will actually get bloody sputum because of the pulmonary artery shunt. And the S1 will sound different. So you have an S1 and S2, your two heart sounds, normal heart sounds. You'll have a, so it's more accentuated. It's not that it's split, but it will be more accentuated. And people that often have mitral stenosis will end up with atrial fibrillation. And part of that is because they also end up with an enlarged aorta because of back pressure. So this just shows you different pictures of the normal valve open and closed, what a stenotic valve looks like open and closed, and shows you if the mitral valve doesn't close well enough if you look over here. So you have a stenosed mitral valve, you're going to end up with, you're not going to get as much blood from the upper chambers to the lower chambers, okay? And if the mitral valve doesn't close completely and you have regurgitation, you're going to get backflow. See how you backflow the blood into the chamber. So with regurgitation, we talked about the door doesn't close well. Rheumatic fever can be part of that. We talked about what their symptoms are. That's a repeat, isn't it? It's a repeat. No, both the stenosis and regurgitation. So the other thing that happens with the with mitral regurgitation is you end up with hypertrophy and ventricular dilation because it affects the ventricles. And with regurgitation, the S1 is decreased. So with stenosis, the sound's increased. With regurgitation, it's decreased. And they still can end up with atrial fibrillation. With aortic regurgitation, what happens is you have a backflow of blood from the aorta into the left ventricle because the valve isn't closing. So syphilis is one, increased blood pressure, inflammation. You ask for all these different, do they have any of these symptoms?